Lifers Podcast. Get with it or get forgotten.
But until then, next question is, how long do you expect students will take until they're more or less independent during their clinical rotation? Like, what's the progression typically?
Right. And I mean, we got to first say, are we talking a, low level, 5 comorbidities, 3, 4 risk factors? Are we talking high complex or low complex? And then if not, here's the other part of the question, is, okay, am I seeing 2 patients or am I seeing 1 patient? So those all have a little bit of the variable to answer that question specific. But I think the progression is independent of the individual, but also set by the parameters of the clinical performance indicator, the CPI. I believe, I assume you all use that?
They're up in the air. There's another one that they're deciding to use, or they might use there's a CPI, and then there's also one more, and I'm losing it, but I know there's 2 that they're thinking about.
All right. Yeah, so I mean, to some extent, that's what's setting the expectation. Generally, like the latter of your 3rd internship, our 4th, we would be required then to be at entry level. So they'll have beginner, advanced, intermediate, and then intermediate, advanced, and entry level. So with each of those internships, generally it's expected that they're going to be at those positions. I couldn't say it blessed, I guess, from the students' sake and my own, that I haven't had any to where we've needed to sit, have discussions, or speak to the director of clinical affiliates there, which is good.
Would you say? Go ahead. I'm sorry, I didn't want to.
Yeah, no, I think it's parameters of the CPI primarily, and then the students also provide their own. What are their expectations? What do they want to get out of their whatever 6, 8, 10, 12-week program? So then I think that's sort of part of our direction as well. Where I've had one, she's like, hey, I want to know more about women's health. Well, even though that's not our setting, I wanted to make sure that they're where she had some time. I had ones like, look, my pediatric clinical rotation actually got dropped, so I won't have that opportunity. Well, here, let's go ahead and give you 2 weeks. So as much as I think it's a great question, and it may be different upon where you go and who, I look for more just what's the growth that you want to get out of this, and with what is required by your education expectation.
Okay, and in terms of, like, let's say, in our case, we have a 12-week rotation. By what week do you typically? I guess like you said, is a CPI. Typically, what week is an average student now going to be one-on-one with a I'm assuming a pretty no comorbidities, a single diagnosis. By what week are you kind of seeing that being the typical?
I would probably say for a first year, like from not within the hybrid programs such as yourself or your colleagues, more so for a first year, I would consider that almost as a tech position, with what the application would be done out in treatment, while then also collectively doing some of the subjective, the objective, special tests won't be applied at that point, just from their minimal or knowledge at that stage. So for them, I wouldn't say that there's ever going to be a level of independence treating the patient, taking them from day 1 out. Second rotation, usually in about 2 weeks. First week for myself, I just leave it as, hey, what's the flow? What's the system look like, just as a whole, for getting patients? Where do I put my laptop? Where is all of the equipment? What is it? So by usually the second week, they'll start to chime in and it's more helpful once that you can do the evaluation and then really then pick up from the ground level to where are we. And that can be, I think, challenging as well, is that when you initially get there, you won't have any of that background knowledge, which is great you're seeking, because you should need to know that before proceeding. So to me, I guess in combination to that 2 week is, once that intern's got the eval, has seen it, they know their goals, they know all the situation, and then they see them throughout, much easier to do that transition independently.
Okay.
And most do well. Yeah.
Okay. I like that. So, okay. Yeah. So, yeah, let's get something to look forward to for sure. I mean, just try to think the perspective of like, okay, 2 weeks into it, we're given not given, but well, obviously it's being facilitated a patient to do an eval and treat. And are you talking maybe you do it once that day and for the first time and see how they kind of do it, or is it kind of like, here you're gonna go 3 in a row individual, and for like how does that how do you approach that?
Well, and a good question. Again, know that all clinics are probably different, and or
Yes.
with companies and organizations and how they set up. So I can respectfully say how my level of consistency has been at our clinic. First off, as mentioned, okay, just basis, get to know what's this look like. I'll provide and I'll demonstrate the manners of how that I would go through the evaluation, and then give them some feedback on why did I choose to do what I did. And from there, we'll most often take just whatever. Objective usually comes the simplest, right? So do blood pressure, reflexes if you find need or presence of paresthesia, so forth. And then there, if you're doing your goniometer, inclinometer, range of motion, so forth. And I think that's would be the most simplest. And then subjective thereafter is what we work with. If you don't, it's not about rushing. It's not about making things happen. It's about going within the flow of what you can do at best. And I think that's the part of where it would be really easy to say 2 weeks for everyone. Some may need a little more time. Some, just like in your subject classes, some are really good at kinesiology, while others are, let's go talk pharmaceutical and microbiology, and I'm great. So it's just finding that common ground of what do I need and how much. Good question.
Okay, and I'm excited to see how the different CIs approach how they evaluate their student, from a day-to-day basis. Like how they know if a student's ready, to take on that challenge. I think is interesting. But to move on to the next one, we're gonna go. I actually kind of goes with this one in combination. It says, what is the expected patient load for a student? 1 per hour, 2 per hour, and how many evaluations does a student typically, do per week?
So again, based on the levels, like by the CPI criteria, generally you're going to be at the 8 to 10 for your latter clinical rotation. Prior to that, usually if it's about 6 to 8 patients, out of those 6 to 8 patients, that most likely would be potentially 1 or at best 2 evals. And I can't say I've had any intern yet that has had to do all 3 evals in one day. It's usually glossy eye or just the haze look and just exhausted for good reason. So again, from myself, it's not about really, yes, productivity is an essential thing from our company, but to the extent that if that's going to sacrifice the quality, the care, and the service that's needed, then I'm not going to push for that as a whole. So 1 hour more than effective is where if you're in your second internship, which is about a 12-week, you can expect on that about 8th week from me that I would then anticipate giving you 2 patients. And that's not like, oh, this is the first treatment of a new patient on top of, oh, this is the patient that has a fall risk and you're going to need to pay attention, right? So again, some level of flexibility, but I think by the end that would be one expectation, Kevin, is that you do have the means of understanding how to treat 2 patients, because more often than not, unless you're in inpatient acute, you're going to have that, or at least from the outpatient, which is what we're discussing.
Yes.
Yeah, you'll eventually need that, but just because you need it, as mentioned, if you're going to put in the predicament where the success and the outcome of this patient is going to be infringed, then we won't do it. It's just not needed.
Like you said, quality over quantity. That's what kind of got you into the PT world. So I definitely love the thought of that. I'm definitely, I love the idea of being able to treat one-on-one, but we understand the world that in the business side of things and how that can affect productivity. And I'm sure we'll continue to see how that kind of changes throughout, the years of our profession. But the next one is when a student has shown up unprepared, regardless of their excuse, what was a piece of advice you gave them?
What do you mean by unprepared?
I wish I knew. I mean, okay, so I'm assuming the student, let's say they arrived late or they didn't wear the right pair of pants or anything of that nature, or maybe they weren't prepared, like they didn't, for a case that maybe they should have been prepared for. How do they best approach that situation? How did you approach it?
Yeah, I mean, depending on, that could be almost considered like a crucial conversation to some stage. So I always think of, just by saying crucial conversation, you have to begin with the end in mind. And personally, as much as I would be one that has still to challenge my emotional intelligence, I think the first thing is really to ask questions and then listen, or have that discussion with the student. Because then when you say, okay, is this a matter of them being unprepared? I think of a few different things. I think of okay, is this because they don't care from a behavior standpoint? Yeah. Two, is it more of a knowledge? I'm sorry, I wasn't aware that was an expectation. I didn't see that in the manual. Or three, or is this out of a fear or out of a concern that sort of drives them the other way and they just shut down? So I want to sort of look at those kind of entities first, then we can be a little more direct on, hey, if this is a knowledge and that was the reason why that you were unprepared, well, let me then provide you with that knowledge so that you can be. Mm-hmm. That's probably the simplest of those elements. But if we're to discuss from this being a behavioral or a lack of motivation, then we need to discuss the why, and why do they not have that motivation? So I think that's my advice, is more about listening, asking, and questioning. And then we can go beyond that. And let's say, okay, it is a lack of motivation, and we find some way to then hold them accountable. We're gonna create, if you want to call it an action plan. We're gonna follow up. We're gonna communicate, and then if we're that they actually do as to be expected, make sure that we commend them as well. Give them that positive reinforcement. I've only had one incident. It wasn't even myself, but a colleague at another clinic, where a young man that would come in and would wear the same pants every day. But what was unsettling was that patients started to come up to the center manager and complain about how can we say, the odor of what he presented with, and also doing manual applications, which were very close, was starting to deter. So that was a conversation that had to be had, challenging one within the discussion. And at that stage, if I had to give an example, now we're just going to go right back to, hey, these are the policies that are established by our company, or as well, most likely that I know you probably have in your some kind of expectations in your syllabi with internship. So there's a few different grounds with that question.
I like that answer. I definitely, we made a list of questions, and I just listening to this, I'll probably have a few more added to it. Yeah. But